وهو قولي اللهم إني أسألك علما نافعا ورزقا طيبا وعملا متقبلا شفاء من كل داء. This is Dr. Zunaira Faiz. Today I am going to discuss the part 2 of the labor and its physiology. And now, under the heading of physiology of second stage of labor, I am going to explain how and when it starts. Uterine action, contractions become stronger and longer, but may be less frequent, allowing both mother and fetus regular recovery periods. In between contractions, there is a period of relaxation, and then we ask the mother to take deep breath. The membrane often ruptures spontaneously towards the end of the first stage or during transition to the second stage. The consequent drainage of the liquor allows the hard, round fetal head to be directly applied to the vaginal tissue. This pressure aids distension. As I told you, fetal excess pressure increases flexion of the head, which results in smaller, presenting diameters, more rapid progress, and less trauma to both the mother and fetus. Uterine action. As I told you, the contraction becomes expulsive as the fetus descends further into vagina. Pressure from the presenting part stimulates nerve receptors in the pelvic floor. This is termed the Ferguson reflex, and the woman experiences the need to push. The mother's response is to employ her secondary powers of expulsion by contracting her abdominal muscles and diaphragm. Soft tissue displacement. As the hard fetal head descends, the soft tissues of the pelvis becomes displaced, interiorly bladder, posteriorly rectum, the levator ani muscles, and parietal body. Soft tissue displacement, as I told you again, the fetal head becomes visible at the vulva, advancing each contraction and receding between contractions until crowning takes place. The head is then born. The shoulders and the body follow with the next contraction, accompanied by gush of amniotic fluid and sometimes of blood. The second stage culminates in the birth of the baby. Presumptive signs of second stage of labor: expulsive uterine contractions, rupture of the forewater, dilatation and gaping of the anus, appearance of the rhomboid of Michaelis show, that is blood, appearance of presenting part. Mechanism of normal labor. Landmarks of the pelvis, as I told you in my lecture of the fetal skull and maternal pelvis. Anatomically, the sacral promontory, this is protuberant. Then is the sacral ala, sacroiliac joints, iliopectineal line, this is the line, and iliopectineal eminence, this one. Superior ramus of the pubic bone and pubic symphysis. This is the pubic symphysis. Diameter of the pelvis, as I told you before in my previous lectures, this is the inlet of the pelvis. It is transversely, the diameter of the transversely is more as compared to the anteroposterior. And then is the cavity, which is equal in transverse and anteroposterior diameters. Outlet, which is the lowest part, its anteroposterior diameter, it is greater than the transverse diameter. It is just opposite to the pelvic inlet. Fetal skull. Here we can appreciate this suboccipito-bregmatic diameter. It is the diameter which is 9.5 centimeter, and it is favorable for the vertex presentation, and it is the normal what the part of the fetus it is presented in the normal vaginal delivery. It is the commonest. And then is the occipitofrontal, again it is 12 centimeter, which is greater, and occipitomental, that is occipito is mental. This is 9.5 centimeters in the face presentation. Birth canal is 10 cm and 9.5 cm the diameter, which easily passes through. Lie. It refers to the relationship of the long axis of the fetus to the long axis of the centralized uterus or maternal spine. This is longitudinal lie. This is, and it is the transverse lie. Presentation. Again, this is the face presentation, brow presentation, vertex presentation, breech presentation, shoulder presentation. Presenting part. It is defined as the part of the presentation which overlies the internal os and is felt by the examiner finger through the cervical opening. Attitude. The relation of the different parts of the fetus to one another is called attitude of the fetus. The universal attitude is that of flexion. Flexion, flexion, extension. Denominator. It is an arbitrary body fixed point on the presenting part which becomes in relation with the various quadrants of the maternal pelvis. The following are denominators of the different presentations: occiput in vertex, mentum in face, frontal eminence in brow, sacrum in breech, and acromion in shoulder. Position. If we see the relationship of the denominator with the pelvis, we can see occipito-posterior, occipito-interior, right occipito-posterior, left occipito-posterior, right occipito-transverse, left occipito-transverse, right occipito-interior, left occipito-interior, and this pubic symphysis, it is occipito-interior. Occipito-posterior is the sacral promontory. Mechanism of labor. As the fetus descends, soft tissue and bony structures exert pressures which lead to descent through the birth canal by a series of movements. Collectively, these movements are called the mechanism of labor. Principles common to all mechanisms. Descent takes place. Whichever part leads and first meets the resistance of the pelvic floor will rotate towards until it becomes under the pubic symphysis. Whatever emerges from the pelvis will pivot around the pubic bone. 6 considerations for normal labor. The lie is longitudinal. The presentation is cephalic. The position is right or left occipito-interior. The attitude is one of the good flexion. The denominator is the occiput. The presenting part is the posterior part of the interior parietal bone. Cardinal movement. Engagement of the head, descent, flexion of the head, internal rotation of the head, extension of the head, external rotation, and restitution. It is the jerky movement. Restitution is the jerky movement which causes alignment of the head as respect to the shoulders of the fetus, internal rotation of the shoulders, and lateral flexion. Head floating before engagement. Engagement. The mechanism by which the biparietal diameter, the greatest transverse diameter in an occiput presentation, passes through the pelvic inlet is designated engagement. Descent. This movement is the first requisite for birth of newborn. Different in nulliparous and multigravid women. Throughout the first stage of labor, the contraction and retraction of the uterine muscles allow less room in the uterus, exerting pressure on the fetus to descend. Following rupture of the forewaters and exertion of maternal effort, progress speeds up. Engagement, descent, and flexion. In this picture, you can see how the baby, the movement is downward and forward, and flexed baby attitude. Flexion as soon as the descending head meets the resistance, whether from the cervix, walls of the pelvis, or pelvic floor, then flexion of the head normally results. Suboccipitobregmatic diameter 9.5 cm is substituted for the longer occipitofrontal diameter 10 cm. The occiput becomes the leading part. Internal rotation of the head. During contraction, the leading part is pushed downwards onto the pelvic floor. The resistance of this muscular diaphragm brings about rotation. Occiput gradually moves towards the symphysis pubis anteriorly. Whichever part of the fetus meets the lateral half of the slope will be directed forwards and towards the center in a well-flexed vertex presentation. The occiput leads and rotates interiorly through 1/8 of a circle when it meets the pelvic floor. This causes a slight twist in the neck as the head is no longer in direct alignment with the shoulders. Internal rotation as it continues. The anteroposterior diameter of the head now lies in the widest, that is anteroposterior diameter of the pelvic outlet. The occiput slips beneath the subpubic arch and crowning occurs when the head no longer recedes between the contractions and widest transverse diameter is born. Flexion is maintained. The suboccipitobregmatic diameter, which is 9.5 cm, usually distends the vaginal orifice. Further descent is the internal rotation. Complete rotation beginning extension. Here you can see this is pubic symphysis, sacral promontory, and this is the anterior fontanelle, it is the posterior fontanelle. Extension of the head. Once crowning has occurred, the fetal head can extend, pivoting on the suboccipital region around the pubic bone. This releases the sinciput. This is sinciput is the forehead of the fetus, face and chin, which sweep the perineum and are borne by a movement of extension. Complete extension, you can see. Restitution. The twist in the neck of the fetus that resulted from internal rotation is now corrected by a slight untwisting movement. The occiput moves 1/8 of a circle towards the side from which it started. Restitution, that is the external rotation. Internal rotation of the shoulders undergo a similar rotation to that of the head to lie in the widest diameter of the pelvic outlet, that is namely anteroposterior. The anterior shoulder is first to reach the levator ana muscle and is therefore rotates anteriorly to lie under the pubic symphysis. It occurs in the same direction as restitution, and the occiput of the fetal head now lies laterally. In lateral flexion, almost immediately after external rotation, the anterior shoulder slips beneath the subpubic arch and posterior shoulder passes over the perineum. After delivery of the shoulders, the rest of the body is borne by lateral flexion as the spine bends sideways through the curved birth canal. Delivery of the interior shoulder. Delivery of the posterior shoulder. Second stage ends with the delivery of the baby. Now, physiology of the third stage of labor. Third stage of labor begins immediately after the delivery of the fetus and involves the separation and expulsion of the placenta and membranes, involving the separation, descent, and expulsion of placenta and membranes and control of hemorrhage from the placenta site. The third stage usually lasts between 5 and 15 minutes, but any period up to 30 minutes is considered to be within normal limits. Mechanical factors. As the neonate is born, the uterus spontaneously contracts around its diminishing contents. The uterine fundus now lies just below the level of the umbilicus. Thus, by the beginning of the third stage, the placental site has already diminished in area by about 75%. As this occurs, the placenta becomes compressed and the blood in the intervillous space is forced back into the spongy layer of the decidua basilis. Here you can see this is the placenta in picture. In the B picture, the blood clot like this, and placenta is going to be separated. Here it is completely separated and then it is expelled out and left over. You can see the uterus. Mechanical factors. Retraction of the oblique uterine muscle fibers exerts pressure on the blood vessel so that blood does not drain back into the maternal system. The vessels during this process becomes tense and congested. With the next contraction, the distended veins burst and small amount of blood seeps in between the thin septa of the spongy layer and the placental surface, stripping it from its attachment. As the surface area of the placental attachment reduces, the relatively non-elastic placenta begins to detach from the uterine wall. What is Schultze method? It is separation usually begins centrally so that retroplacental clot is formed. Increased weight helps to strip the adherent lateral borders and peel the membranes of the uterine wall so that the clot thus formed becomes enclosed in a membranous bag as the placenta descends fetal surface first. This process of separation is associated with the more shearing of both the placenta and membranes and less fluid blood loss. Matthew's Duncan method. The placenta may begin to separate unevenly at one of its lateral borders. The blood escapes so that separation is unaided by the formation of a retroplacental clot. The placenta descends, slipping sideways, maternal surface first. This process takes longer and is associated with rapid, incomplete expulsion of the membranes and a higher fluid blood loss. This you can see in the Duncan's method and Schultze method. This is how it is expelled, and here how it is expelled. As it is started from the detachment starts from the center, and here detachment of the placenta starts from the sideways. Separation of the fetal membrane. The great decrease in uterine cavity surface area simultaneously throws the fetal membranes, the amnion, chorion, and the parietal decidua into innumerable folds. Membranes usually remain in situ until placental separation is nearly completed. These are then peeled off the uterine wall, partially by further contraction of the myometrium and partially by traction that is exerted by the separated placenta, which lies in the lower segment or upper vagina. Hemostasis. How the homeostasis is maintained. Retraction of the oblique uterine muscle fibers in the upper uterine segment through which the tortuous blood vessels intervene. The resultant thickening of the muscles exert pressure on the torn vessels, acting as clamps, so securing a ligature action. Here you can see this crisscross arrangement. It helps and it gives the strength to the musculature. Homeostasis, as we continue with this, vigorous uterine contraction, falling separation. This brings the walls into apposition so that further pressure is exerted on the placental side. There is transitory activation of the coagulation and fibrinolytic systems during an immediately following placental separation. With that, thank you. I hope this will freshen your knowledge. Jazakallahu khair.